I request all participants to keep themselves muted at all times and send us your questions only via the chat. To submit your question, simply type the question into the chat box and click send. We will have a consolidated question and answer session with both the speakers towards the end of the presentation. Please note, with this webinar, we will be giving certificates of attendance also. All those who complete the webinars and wish to be provided with the certificate must fill up a form which we will provide to you at the end of the webinar. This form only asks for your email as well as your name and the title as you want it to appear on the certificate. Only those who will fill out the form will be provided with the certificates. I would now like to introduce our first speaker, Dr. Anushree Gaigawale, who's the head of Department of Microbiology at Suburban Diagnostics. Having obtained her degree of MD in Microbiology from GMCH Nagpur, her DNB in Microbiology from the National Board of Examinations in New Delhi, and her diploma in Infection and Prevention Control from University of Hyderabad. She has previously served as an associate professor at the GMCH Meerut and as a consultant microbiologist and doctor in charge of COVID-19 at Metropolis Healthcare. She is at the tip of the spear when it comes to infectious disease testing at Suburban Diagnostics. Without further ado, let me hand over the reins of this webinar to Dr. Anushree. Over to you, Dr. Anushree.
Thank you, Dr. Jyot, for that kind introduction. Good evening, everyone. I am Dr. Anushree Gaigawale, Head of the Department of Microbiology, Suburban Diagnostics, Central Processing Lab, Mumbai. My today's topic for the webinar is Advanced Molecular Diagnosis in Respiratory Infections. Next. Since the time medicine has been practiced, the clinical diagnosis has always been syndromic based. But when it comes to testing, it was never. So what exactly is this syndromic approach when it comes to testing? It is a symptom-driven broad grouping of probable pathogens into one, and a rapid test that maximizes the chance of getting the right pathogen responsible, that too in a clinically relevant time frame. Next. Syndromic approach, why is it needed? We have a lot of diagnostic tools available, but then majority of them are time consuming. They are technically challenging, requiring labor intensive. In spite of all this, they are yet low yielding and lacks the sensitivity and specificity. Also, as against the syndromic testing, these traditional tests need to give multiple tests specific for the organisms. Also, the tests are not available for all the organisms. Next. So this is it. In traditional testing, we have one sample from which we order multiple tests, which may take days for the result to come. And by the time the management of the patient is not specific. As against syndromic testing, from the one same sample, we go for one comprehensive test, which targets for multiple pathogens in the differential diagnosis, yet the result is available in hours, and it helps in the management of the patient. Next. So Biofire film array is the answer to the syndromic testing. Why? It is the fastest way which provides better results. Also, it's recommended because it's FDA, CE-IVD, as well as TGA certified multiplex PCR synth. How does it work? It's a completely automated protocol, and because of which it has got an integrated sample preparation inbuilt system. Also, the result analysis is automated. So despite of a massive multiplex PCR, because of all these qualities, it is available to give us the reports very fast. Next. This is how usually a run is set in the Biofire panel. As we are dealing with the respiratory infections, I'll be discussing the respiratory panels a bit in detail. So whenever we receive the respiratory samples, there are the specific panels provided by the Biofire film array. It has been loaded with the samples and the hydration solution, and the pouch is then run in the system. Next. Within the system, we are already aware that all the PCRs are automated. So what is it that makes the film array different from the typical PCR reaction? So for a typical PCR reaction, we require one sample, but then that is to be first processed to get the DNA or nucleic acid extractors. Then these nucleic acids are further treated with the sample reagents and then subjected to the analyzers and the multiplex for the next steps, which is time consuming. As against to this, when we receive a sample, we load the sample along with the buffer, and the hydrated is injected in the pouch as mentioned earlier. And this pouch is just to be loaded in the multiplex PCR of the Biofire. That is how we get, in spite of the multiplex and the PCR, we get the reports faster in case of the Biofire panels. Next. As already mentioned, it's a multiplex PCR. What exactly that means? That is, it simultaneously targets the complex numbers of pathogens which are included in the differential diagnosis in one single sample. Next. Even the result analysis in case of Biofire is automated. Also, it is very simple to interpret as it gives for each parameters into positive or negative, which comes in the reports as detected or not detected. Also, this automated result analysis removes the specific interpretations. All these qualities helps us in getting the report really fast, which is almost 1 hour the machine runtime. Next. So the panel specific to today's topic, the first one being the Respiratory 2.1 panel. This panel covers 21 targets, which includes the pathogenic viruses and the bacteria. As we all know, there is no culture system for the viruses, and many of the viruses requires a symptomatic treatment. And second is the bacteria. The 4 targeted bacteria are the atypical bacteria, which are difficult to grow. So this panel really helps in critical cases patients wherein a report is to be achieved in faster time. So the sample type of this specific panel is the nasopharyngeal swab in transport medium. The sample volume is also minimal, which is 300 microliter. The performance for this test when compared with the culture system was found to be 97% sensitive and 99.3% specific, which signifies that the report that we get are reliable, basis which the clinicians can start there for management of the patient. Now, this is a dummy report to show the report format for the respiratory panel, wherein, as I have mentioned earlier, each parameter, like in this panel, the viruses and the atypical bacteria are being tested, and against each the result is being given as detected and not detected. Next. Next. Another panel for respiratory infection is the pneumonia plus panel, wherein it targets 27 pathogenic organisms. Now, along with the viruses and the atypical bacteria which were there in the earlier panel, here we have the common bacteria which causes pneumonia, the gram-negative bacilli as well as the gram-positive organisms. Now, this system provides if bacteria is been identified, the result is given in semi-quantitative format. basis which an analogy can be made about the severity of the infection. If any bacteria is being detected, it also goes a further step ahead to detect for any antimicrobial resistance genes. In this panels, it includes all the 4 genes of carbapenemase resistance and the 3 genes for the beta-lactamase resistance. And for the gram-positive cocci, the methicillin resistance genes. Resistance genes further helps in the course of management of a critically ill patient. Next. The sample type for pneumonia plus panel is sputum, including the endotracheal aspirate and the bronchoalveolar lavage or the minibar. Here too, the minimal requirement of the sample volume is just 300 microliter. The performance for this panel for BAL sample is around 96% sensitivity and 98% specificity. And for the sputum sample, it is 96% sensitivity and 97% specificity. Again, emphasizing that the reports are reliable for deciding the further management of the patients. Next. So what are the advantages of the Biofire panel? For the clinician and the patient, it helps us to get the exact diagnosis, the exact organism, pathogenic organism, that too in less time. Along with that, it also helps in at times the diagnosis of the organism which may have missed in the differential diagnosis. This panel is also very helpful in the diagnosis of superheaded infections or the co-infections. All these 3 advantages helps the clinicians to take their decisions for the management protocol of the critically ill patient. Thus, providing the better and faster reports also helps the hospital care facilities in generation of the savings. Next. So overall, Biofire panel helps us meet the healthcare facilities needs, that is better and faster reports which are reliable for deciding the further course of management of the critically ill patients at affordable yet profitable rates. Also, the inclusion of the resistant genes in the Biofire panel helps in the building policies and guidelines for infection control and building updating the antimicrobial stewardship policies of the healthcare facilities. Next. Having said about the Biofire panel, the other respiratory tests which we provide is the bacterial culture and the antibacterial sensitivity. Along with that, for the TB identification, we have the rapid automated midget system. Further going, we can do even the drug susceptibility testing. Faster reports can be obtained from the multiplex cartridge-based nucleic acid testing, which is the GenExpert TB. Currently, we are doing the multi-drug resistance ultra panel of the TB. We are soon to launch even the extensive drug resistance TB panel. Along with the bacterial test, we also provide testing for the fungal pathogens in respiratory samples. Next. These are all the 5 panels of the Biofire that we provide with. The respiratory panels I already discussed. Other than that, we have the gastrointestinal panel, for which the sample type is stool. We have the meningoencephalitis panel, the sample type is CSF, and the blood culture identification panel, the sample type of which is a positive blood sample flagged from the automated system. So these are the sample types and the temperature at which the samples are to be sent to the lab. Thank you all for your patience listening.
Thank you so much, Dr. Anushree, for that informative presentation. I would request the audience to put in their questions in the chat box. We will be answering all the questions that you have put in the chat box after the end of the second session. Please keep adding your questions to the chat box. Let me now introduce our second speaker, Dr. Vikrant Shah, who's a senior physician, intensivist, and infectious disease specialist at Zen Multispeciality Hospital in Chembur. Armed with an MD in internal medicine from Grant Medical College and a fellowship in infectious diseases, he has been a dynamic orator in various training programs, web telecasts, and other forums on the national and international stage. He is famous for his weekly CMEs for the general practitioners, focusing on various topics of interest in general practice also. Newer developments in treating of HIV infections, multi-drug resistant infections in the geriatric age groups in the ICCU, and advanced diabetes management are some of his areas of interest. Dr. Vikrant Shah, the screen is all yours. Thank you.
Thank you, Dr. Jyot, for the warm introduction. And good evening, everyone. Good to be here on Saturday evening and talking something really, really nice. And the stage is already on fire because of Dr. Anushree. She's already given a nice introduction and overall view about what is Biofire all about. So she's made my talk really, really easy. So we'll be speaking about something like non-COVID-19 use of Biofire in clinical practice. We all know that we've been evolving over a period of time in the medical management, be it any field or be it any system. For example, we've evolved over a period of time in the management of diabetes, gone those days wherein we speak about lifestyle modification alone. We think about lifestyle modification, we think about addition of metformin and additionally another drug if your HbA1c is more than 1.5. So it is like hit hard and hit early. We think about starting antiretroviral therapy right in the beginning in patient who's diagnosed with retroviral disease, provided that patient doesn't have any opportunistic infection. Similarly, the guidelines for hypertension have changed. So the same thing is applicable for infectious diseases. So we've not only evolved in terms of the management protocol, but even organisms have evolved. The clinical presentation has changed big time. So considering what has been taught to us by our professors in the past when we were medical students, in line with that, we need to take help of the recent advances to be in line with the evidence-based medicine and to practice evidence-based medicine. So what is that and how to extrapolate what I am saying into clinical practice is what I'm going to tell you all quickly vis-a-vis with reference to Biofire testing. So just to give an example, like for example, respiratory infection. So broadly we divided into upper respiratory infection and lower respiratory infection. So most of the time we are aware that upper respiratory infections are likely to be viral. Obviously, we take help of the clinical history, the examination findings. So similarly, it has been taught to us, unless and until patient has significant expectoration, we cannot call that as lower respiratory infection. More than 60 cc of sputum per day basically tells us that the lesion is into the lower respiratory tract. Now, patient cannot calculate each and every quantity of the sputum, but on an average, patient can tell you a mug full of sputum in 24 hours. That tells us indirectly that it is significant expectoration. So this significant expectoration and this significant word makes it very significant to tell us that we are dealing with a lower respiratory tract infection. Now, dealing with lower respiratory tract infection, your detailed history is very, very important. So take from there, we ask our patient, what is the color of the sputum? What is the color of the expectoration? So that color of the expectoration tells us indirectly what organism you're dealing with. So whether it is a green color sputum, whether it is a rusty sputum, whether it is mucoid sputum, whether it is blood-stained sputum, that kind of tell us we've learned in medicine what organism will lead to which color of the sputum. So based on that, we used to empirically start on antibiotics. That used to help, that is to save exposure to antibiotics. the day and era wherein we are, you must be remembering what was said by Infectious Diseases Society of America in the past 5-6 years back, that developing countries like India, people will die with tonsillitis. Now, why such a profound sentence? This profound sentence came into picture because of evolvement of the bad antibiotic resistance. So for every damn patient used to get exposed to antibiotic, and we started seeing the antibiotic resistance. So gone those days wherein we don't speak about save tiger anymore. We speak about save antibiotics. Now, how do we do that? So that is why we need to know our basics well, and we need to take help of the recent technologies like the Biofire testing, that to confirm that we are dealing with a bacterial pathology and not a viral pathology, and which particular bacteria and what antibiotic needs to be used so as to save our own antibiotics. I'm sure you're aware about the statistics, how bad the antibiotic resistance is a problem overall globally, and how much is the mortality which is associated with antibiotic resistance. So which is a big problem. COVID has taught a lot many things. In COVID, managing COVID, we've seen the presentation can vary. I'm not even getting into the different mutations. I'm talking about a basic clinical presentation which we saw and which is varied. We could see 18% of the population getting only GI symptoms in COVID, not even having a respiratory symptom. So on and so forth. We also saw there is a mixed infection wherein it was viral infection with bacterial infection. So we want to save time, we want to save antibiotics, and how do we use these particular tests? What Dr. Anushree has already spoken about, what is Biofire, so I'm not wasting time there. It is an integrated testing wherein we use a sample preparation, amplification, detection, and analysis by using the Biofire system. Now we have different panels which is available. Respiratory panel, which is the center of the talk today. But I'll be putting light on something like blood culture identification, gastrointestinal Biofire, and meningitis or encephalitis and pneumonia panels. So it's a PCR testing. So it's very fast, it's accurate, it's easy, it's comprehensive, it targets multiple things. And in both respiratory as well as pneumonia panel, she's already told us that you have a good sensitivity and specificity ranging from 96 to 99%. Now, this is one of the important slides. Use of Biofire film array respiratory panel was shown to reduce chest radiographs in children by 19%. So very, very important. We've seen last couple of years, the extensive CT scan being done as a part of COVID protocol. So that's a good amount of radiation. Keep COVID aside. That is why the topic is use of Biofire in non-COVID setting. Imagine children getting exposed to alpha, beta, gamma rays. And if you use a Biofire system based on your clinical judgment, based on patient's clinical history, what is the type of cough, whether it is with expectoration, without expectoration, whether associated with chest pain, without chest pain, whether chest pain is pleuritic pain, non-pleuritic pain, how many days of cough, any other organ involvement. Based on that, you have kind of a working diagnosis on history taking and on clinical examination. And if you have something like Biofire, which gives you organism within an hour's time, I'm sure you can avoid getting an X-ray done because you know the radiation risk and the radiation hazards. The percentage of test results reported while patient is still in the emergency department, you can see with reference to standard testing wherein we used to do typical X-ray test or sputum test or get the cultures done or wait for your cultures. As compared to that, if you have the Biofire respiratory panel, you have 51.6% more benefits as compared to the standard testing. So this is in percentages. She's already shown you this. So I'm skipping this slide. What are the different viruses and the different bacteria what you get in? We all know, I mean, this also shows something like atypical organisms. We all know the typical respiratory infection and the class criteria. The class criteria is basically to decide whether patient requires hospitalization. So cough with significant expectoration, fever a high-grade fever, pulse rate more than 120 or less than 60, respiratory rate more than 24, oxygen saturation less than 90, blood pressure less than 90 by 60 millimeters of mercury. All this suggests and fulfills the CRAS criteria for hospitalization and generally tells us that this is a classical community acquired pneumonia, which is secondary to usually has a group of organisms. But how does it differ from atypical pneumonia? Your symptoms would be there, but your examination findings won't be so much. Patient would not have significant expectoration. Patient would have a patch on the lung on an X-ray testing, but would not have significant expectoration. Patient would be breathless. So the signs would be out of proportion than what you see and what is the history is like. So those organisms, like for simple example, if at all I have to think about Mycoplasma or Legionella, I would do the X-ray, I would send the urine test for Legionella, I would send the IgM Mycoplasma, and I would also do the blood culture as well as the sputum culture, but conventionally waiting for that report. Until then, as a protocol, if patient is hospitalized, starting something with the BSBLI cover, so patient is exposed to antibiotic. But if I'm getting the time around time is less, and I'm coming to know that I'm dealing with an atypical organism like Mycoplasma, I would be happy starting patient on simple azithromycin, and I'm sure patient is going to respond well. So I'm saving time, I'm saving patient's money, I'm saving exposure of antibiotics like cephalosporin sulbactam or piperacillin tazobactam. Obviously, I'll be taking help of the clinical examination findings. I would also look at the color of the expectoration. I would look into the CBC to look at the WBC count, the neutrophil count. I would have a look at the X-ray chest to decide the clinical findings. I would apply the class criteria, but patient is fulfilling the clinical criteria for atypical pneumonia, and I'm getting a result in an hour's time, I'll be happy starting patient on azithromycin or clarithromycin, whatever is suitable and available in your setting. Also, coming back to COVID, we also could see 20.7% of the population had co-infection. So it was not only the respiratory viral infection, they had simultaneously concomitant bacterial infection. So this biofire would help me telling me that there is a bacterial infection also, and I'm justified in starting patient on the antibiotic support. Otherwise, COVID, there is no role of the antibiotic. Also, there are various respiratory infections like respiratory syncytial virus infection, influenza virus infection, para-influenza virus infection, which requires essentially symptomatic treatment, no role of antibiotic. So this is going to be a clinical use wherein we come to know what organism it is. She also mentioned while doing the culture, we also come to know about the resistant genes. So which tells us if I'm dealing in the ICU, patient is already, like for example, I'm treating my patient in ICU and Dr. Anushree has already told me that this gentleman or the lady is growing gram-negative bacilli, and on day one, she's finding some growth suggestive of gram-negative bacilli. I would request her, since this is the blood sample which is showing culture positivity, please go ahead and do the BCID panel on them. If I'm suspecting resistance, if patient is transferred some other hospital and patient was already on carbapenem drugs, and I'm suspecting carbapenem is resistance, I get an answer within less time as compared to waiting for conventional time period wherein she would do the culture sensitivity, she would apply the sensitivity. I save time and I put patient, if I'm getting something like OXA 48 or NDM or WIM, I'm happy to start patient on those reserved antibiotics like ceftazidime, avibactam, or astronam for that matter in the ICU, and patient is better. So the mortality is definitely coming down, morbidity is coming down, the length of hospital stay in the ICU is coming down, patients is saving money eventually. So saving costs for the hospital as well as the right antibiotic for the right amount of time period at the right time. So that's an advantages. So similar things are advantages what I just spoke about. So conventional 9.2 days as compared to 6.2 days with the the Biofire adoption. So respiratory panel also, she's already told you all about 33 targets in one test. Fabulous. So we don't really, such a comprehensive, data we get from it. So I'm pretty happy with it. We also definitely need to know whether we are dealing with something like a pathognomic organism, or we are dealing with a colonizer. So it would not pick up something which is below 10 into 10 3 to 5 copies per ml, which would be reported as undetected. But we need to understand, with help of our clinical judgment and the patient's presentation, whether you're dealing with a common cell or the a pathognomic bacteria. Here, if we could see the bile specimen as well as the sputum specimen, the Biofire pneumonia panel detects more pathogen than culture. It is difficult to grow organisms in culture if they are fastidious in origin, or if patient is on antibiotic when the sample is connected. So that is a drawback of doing the culture and identifying and then putting the sensitivity for that. It also identifies the nucleic acid even when the microorganism is not grown in the culture. So it's really advantage. If you could see in the picture here, culture positive in BAL is only less than 1%, and in sputum specimen less than 1%. As against that, both techniques negative is around 39% in sputum, 62% in BAL. Both techniques positive in around 34%. And culture positive data is such very low. So that is why it tells us with evidence that your Biofire is such an advantage. Similarly, when we apply this technology, PCR technology, which identifies around 33 targets, even though they are not grown in the culture, if we go into the traditional method, if we see the bacteria only accounts for 11%, 3% is only for the bacteria virus co-infection. But if we apply this, you have a yield of more than 60% picking up bacteria viral co-infection and virus alone. Also, put a small note on gastrointestinal symptom. So since we are speaking about gastrointestinal system, I also forgot to mention, since I'm talking about GI system, it is associated with GI. The longer the use of antibiotic, there is a longer risk of something called as Clostridium difficile infection. Also, the tests like C-reactive protein, procalcitonin level are being done regularly in corporate hospitals on a daily basis. That also accounts for a cost. So if we have something which is available in less time, we also save on that cost. So cost for the patient, cost for the society, so cost on healthcare system. So this is an advantage. Coming back to the GI panel, you have the various bacteria, you have viruses and parasites. So if I'm getting a GI panel done and that clearly tells me that I'm dealing with a rotavirus or an adenovirus, I'm just going to give patients a symptomatic treatment. Patient doesn't require antibiotics. So many times we've seen every patient of diarrhea coming to us. Patient wants to save time. Patient doesn't want to do any test. They are reluctant doing the stool testing also. Eventually, they end up getting a combination of cephalosporin with ornidazole or quinolones with ornidazole, metronidazole, so on and so forth. So we can actually avoid. If you're dealing with certain organisms, you require a specific antibiotic for that. Your one size fits all cannot hold true for the diarrhea or the bacillary dysentery. If you're dealing with parasite, you need specific treatment for parasite. If you're dealing with a patient with immune compromised status like HIV patient post-organ transplant, on disease-modifying agent, patients on steroid for some reason, uncontrolled diabetes, you can have various atypical organisms also, so which require specific treatment. So that is why this is very important. So which of diarrhea patients or which of the patients who you feel would get benefited with your GI Biofire testing? So patients presenting with dysentery, diarrhea with fever, severe abdominal pain or cramps, having established signs of sepsis, which could be hypertension, which could be cold clammy extremities, severely dehydrated, moderate to severe disease symptoms lasting for more than 7 days, and all immunocompromised patient, which I just mentioned. So you would require very less amount of antibiotics if you use this and use a targeted therapy. So you actually go bang on. So you have a fast turnaround time of 1.7 hours as compared to 61 hours in conventional testing. So that's a long time for patient to have diarrhea not getting a bullseye treatment. So this she's already shown, like for example, as compared to conventional testing, you have a classical uh, Clostridium difficile or rotavirus negative patient retrospectively tested, retested using Biofire. So 22% of the patient for unsuspected pathogens, and only 20% had the negative Biofire. So 60% of the patient we could give them an off isolation treatment. Otherwise, a typical patient coming to with a typical syndromic presentation, we usually keep them in isolation unless you prove. So as against the conventional testing, which would incur a lot of time. So having a separate bed for isolation, so that would incur a lot of cost. As against that, we save that cost as well. Coming back to the meningitis and encephalitis panel, you have bacteria like E. coli, K1, H. influenza, Listeria monocytogenes, Neisseria meningitidis, Streptococcus agalactiae, and Streptococcus pneumoniae. Picking up viruses like cytomegalovirus, enterovirus, HSV1, HSV2, human herpes virus 6, human ecovirus, and varicella zoster virus, and yeast like Cryptococcus neoformans or Cryptococcus incerti. You can have that pick up in 24 to 48 hours. So your diagnosis is very, very critical in patients of meningitis, which can be fatal in 24 to 48 hours. If you reduce your turnaround time, you actually have a targeted therapy and patient gets better fast as compared to the empirical therapy, which will lead to lengthy hospitalization, unnecessary antibiotic use, all of which add to overall cost to the care. So the diagnostic yield 2.7% overall increase for adult patients, 2.3 overall increase for pediatric patient, 3.3 days reduction in the adult patient. So for the diagnosis, 4-day reduction for the pediatric patient in diagnosis, which is a huge, huge, huge benefit. Impact of antimicrobial therapy, so 2-day reduction in both acyclovir and antibiotic duration in adult patient. So you save not only acyclovir, but you save the load on the kidneys. 2-day reduction on both acyclovir and antibiotic reduction in pediatric population. 2.2 reduction in the length of hospitalization stay for adult, and 2-day reduction for the pediatric population. So this is how it differs. If you could see top here, line 14 pathogens in one comprehensive test in an hour's time as compared to CSF examination doing the gram staining, in-time preparation, rapid agglutination test, traditional targeted PCR for our CSF cultures, and getting the results, which incurs a lot of time. You can see it is so very beneficial. That is why it is come into the Infectious Diseases Society of America guideline as well, that rapid diagnostics test should be considered to determine the bacterial etiology of meningitis. PCR excluding bacterial meningitis influencing decision to initiate or discontinue antimicrobial therapy. Rapid PCR detection of enterovirus, which reduces the shorter hospitalization stays and reduce the use of antimicrobial therapy. That's for meningitis. And for encephalitis, more than 10% of the patients with viral encephalitis can have normal CSF findings. PCR should be performed to establish the specific cause of encephalitis, to identify the organism and treat it appropriately. Acyclovir should be initiated in all patients with suspected encephalitis clinically, but if you pick up the bug, you can actually reduce the burden of acyclovir as well. In patients with negative herpes simplex 1 and 2 PCR results, repeat testing before modifying the treatment. So blood culture, I've already said that gram-negative organisms, gram-positive organisms, yeast, enterobacteriaceae, fungal and anaerobic pathogens, identification of coagulase negative staph species, and 10 antimicrobial resistant gene, which I have already said that she would be using this on a positive culture methods, and you have 33.5 hours faster results to shorten the time of the therapy, reduce the hospital stays, and save antibiotics. So to conclude my talk, syndromic testing from Biofire can help us improve operational efficiency, which is rapid, easy, reduce unnecessary testing, which is going to be as accurate as with a sensitivity and specificity of 96 to 90.9% put confidence into the treatment plans and prescribe the right treatment sooner. Thank you very, very much indeed for your kind patience. I will be happy to take any questions.
Thank you so much, Dr. Vikrant Shah, for that illuminating presentation. It was so clear from your talk and Dr. Anushree's talk as to how when patients present with similar overlapping symptoms and how when the clinicians are not in a stage to identify the organisms earlier, how a biofire or a syndromic panel can help faster comprehensive results with better improved clinical outcomes. And obviously with that decreasing the number of days of stay in the ICCUs and the duration of the antibiotics that are pumped in for the patients. Before we start the Q&A session, I have a small announcement. We will now be collecting details of all the attendees for the certificate. A new link has been posted in the chat box. The initial link had some issues. We apologize for that. Please click in the new link. Please click on the new link and you will find a Google form that will open up. You can fill in the details and be rest assured you will get your certificate via an email. Only those attendees who will fill up the form will be provided with the certificate. And once you have entered these details and submitted the form, you will receive the email within 7 working days in your inbox. We now have the question and answer session. We have Dr. Vikrant Shah and both of them. Can we have both the panelists switch on their videos? Dr. Vikrant Shah and Dr. Anushree. Yeah. So Dr. Vikrant Shah, we have a question for you. How many percentage of cases where CSF is the sample would you find a positive pathogen?
Right. So I would take it. There's this question from Dr. Hina Satam. So probably she's meaning what is the sensitivity and specificity for CSF biofire, if I'm not wrong in taking that question. So probably again, it is ranging between 96 to 99%. Correct me if I'm wrong, Dr. Anushree. Dr. Anushree, you're on mute.
Me unmute. Yes, sir. That's correct.
Yeah.
The panel sensitivity is approximately 96%.
Well, it is given in the literature 96.4 to 99.3% is
specificity.
Sensitivity and specificity.
We have a question for Dr. Anushree. How much sample quantity is required in case if someone wants to send an aspirate or a pus aspirate or a pyogenic aspirate from a FNAC sample from a lymph node or something like that? How much is the minimum quantity of sample that is needed to obtain a proper diagnosis?
Pus sample, I mean, for the biofire panels?
Yeah, if can somebody send a pus sample from an FNAC aspirate?
No, that sample type is not the preferred sample type for any of the 5 biofire panels we are having.
Right. Is there anything known as a false positive in a biofire panel or a false negative, Dr. Anushree?
Yes, sir. Like we have seen that the sensitivity is variable from 95% to 97%. So obviously that gives us that false positive and false negative chances are there. But then as they have already mentioned, the reports or the results of the biofire panel testing are always to be clinically correlated. And if possible, we should also parallelly run the gold standard for infectious disease, which is culture testing.
Dr. Anushree, a question for you again. Any special precautions to be taken while collecting the sample for biofire panels? pre-analytic precautions?
Except for the specific sample that is required basis the panel, the pre-analytical conditions that are required are the overall general conditions only. That is, all the septic precautions are to be maintained. Then the temperature which is to be maintained is at 2 to 8 degrees centigrade. Then in case of the respiratory pneumonia panel, we need to have like the sputum or the endotracheal aspirate and the bowel samples. Then in case of the nasopharyngeals, the respiratory panel, we need to have the nasopharyngeal swab to be sent in the media. Then in case of GI panel, there is a specific requirement that either a frozen stool or in the stool specific transport medium, it is to be sent. And most importantly, I would like to emphasize, good that this question has been asked, like for the blood culture panel, even Dr. Vikrant Shah has emphasized that the primary sample which will be processed is a positive blood sample from any of the automated system. Like unlike the other 4 samples wherein we directly process the patient samples, in the blood culture identification panel, we need to have a positive blood samples.
All right, Dr. Vikrant Shah, one question for you. Can the use of antibiotics or antivirals before sample collection hamper the results? Actually, it's more of a joint question, but
right. Frankly speaking, for viral infection, there is no specific treatment unless we are dealing with something like H1N1, wherein we've been using oseltamivir. But other bacterial organisms, definitely, normally it would make a difference in terms of the conventional culture method. But in the presentation which I showed, wherein I'd given the comparison of picking up with help of Biofire, so patients who were not picked up on blood culture also been picked up on Biofire. So starting the empirical treatment for a day or two should not hamper the result. That is why we're talking about that high sensitivity and specificity.
Fantastic. I would really like to thank Dr. Vikrant Shah and Dr. Anushree for giving their time, and I hope all the participants have had a good academic feast in this session. I would request all participants to make sure they click on the link that is provided in the chat box and feed in their details in the Google form so that we can send across the participation certificates on your email ID. Thank you so much for this. I appreciate your participation, and thank you once again, Dr. Vikrant Shah and Dr.
Thank you. Thank you, Dr. Jyot. Thank you. Thank you, Dr. Anushree.
Thank you. Thank you, Dr. Vikrant.